Hi, Jessica. Um, I sent out a lot of announcements this week. Was the weekly roadmap for the rest of the term helpful? Has anybody read through that? Are you guys getting your exam, HESI exam scheduled? Yes, no, having trouble?
Now, how
Any-
do we do that? Because when I go to where we need to register for it, there's nothing coming up.
Julie, what campus are you from?
Westerville, Columbus.
Oh, it should be all set up. The only schedule we don't have yet is Norfolk, and I don't believe I have anybody from Norfolk in this class.
Yeah, because I'm taking it. I looked at the times you sent. I'm taking it the 21st at 7,
Oh,
but
okay.
I can't get online and register for it.
Oh, okay. Well, that's a question for your campus.
Okay.
Okay. I don't have anything to do with the schedules except providing you a snapshot of when they are. Norfolk, let's see, Taiwana. Have they given you anything yet?
No, I haven't gotten anything.
Yeah, I think so far Norfolk is the only campus that is, I don't have a date and time yet. But everybody else should be, so let's see with our Columbus students. Julie, have you been able to schedule yours yet?
No, when I go to register for it, there's nothing that comes up. The only thing that comes up for me are like previous classes that I've already taken
Okay.
to register for.
Okay, Tara, what about you? Have you been able to schedule your HESI yet, Tara? Jason?
Julie, did you try removing your cohort?
Yep. And that's when like Jerry and Farm and all
okay.
that popped up for me to register for those. And I'm like, that's not right.
Jason, have you been able to schedule yours yet?
I haven't tried yet.
Okay, all right. And then Jessica, you're from, where's Jessica? Jessica, I know I see you somewhere. There you are. Have you received any information from your campus about scheduling your HESI?
No, I'm from Norfolk.
Right. Okay. And Rochelle, you just came in. Rochelle, are you there? Okay, well, they do have the date set up, so if you're having trouble, I would reach out to your campus. Okay, I'm not sure why you can't schedule it yet, but you'll have to reach out to your campus, but know that that's what you should be doing in the next, because you guys go right next week, right from an exam to the following week for a HESI. I'm going to try and do a HESI review next weekend. And I think Professor Kershaw is going to try and do one as well. How are you guys coming on your HESI prep worksheet? You guys working on it?
Yeah.
In reviewing the past couple of terms HESIs, those are the topics they're covering for HESI questions. We don't have anything to do with developing the HESI. It's like NCLEX, it comes from a test bank. And so the only thing we can do, we can't even look at the questions. We can just look at topics that are covered. So that's what your HESI prep is. Topics that have been covered on previous HESIs. There's only been 2. Okay. What do we got? I'm going to share my screen. Anybody have any questions? Let's go in here. I want to go to the module. How are you guys coming on your vulnerable populations assignment?
Pretty good.
Okay. Okay, so this
Professor
week,
Marvel,
yeah.
For the PowerPoint, are we supposed to do it together as a group or individually?
This is an individual assignment.
Okay.
Okay, if you look in your week 10 module right here, Jessica,
Mm-hmm.
it gives you what you need to know right here.
Okay.
Okay, rubric and everything.
Okay.
Okay, and so this week your HESI prep assignment is due Sunday, as well as your NCLEX questions. Okay, and then you have your domestic violence and cultural competency case study. Okay. Any questions? Okay, let's cover, let's go to our fundamentals first. Okay, well, let me go back. Whoops. This is what we're covering today. Okay. Chapter 45, which the part of chapter 45 that is care of the patients with emergent conditions, trauma, and shock. Okay, and then we're going to cover a few pages and legal and ethical aspects of nursing in chapter 3. And then we're going to cover a couple of cultural and spiritual aspects of care. I sent out week 9 notes just today because I had to clean up the cultural competency, cultural and spiritual aspects. So I'll pull those up. So let me show you what I sent you today, just a little while ago. All right, so I want you to use these. I actually sent you an announcement with week 7 and week 9 notes. Okay, so this is what we're going to cover today, cultural competence. Okay. And chapter 25. I don't think we have chapter 25. We're going to cover the top part of this, cultural competence. Okay, so let's go back and do our let's start with chapter 3. Let's see. Okay, so a few things we need to know out of this chapter, and I've highlighted them. Okay, it says pages 35 and 41, but we're also going to cover chapter 30, page 38, because that has to do with HIPAA. And there are some questions on the exam about HIPAA. Okay, and that's in your study guide. So first part I want to cover with regards to legal and ethical aspects is patient care partnership. Okay, so I'm on page 35, and this looks like box 3.2. Okay, and so how is a patient care partnership developed by you and your client, since it's a mutual contract, mutually agreed upon partnership? Okay, and what kinds of things do patients expect for their hospital stay?
No.
Okay. There's some,
Might be hurting.
let's see. Need to mute. Okay, so when you are in need of hospital care or a family member, right? The hospital team should be committed to working with you and your family to meet your needs. Right? So the goal is for your family and you to have the same kind of care and attention that we would want, or be giving the same kind of care and attention that we would want our own families to have, and ourselves, right? So how do families expect to be treated during a hospital stay? Okay, and this is a list. High quality care, clean, safe environment. They want you to be involved in their care. Right? They want you discussing the medical condition, information about treatment choices. Right? Do you have these kinds of conversations with your clients when you work with them now? Are these the kinds of things you talk about? Treatment plans, getting information for them, getting resources for them. Do they understand the goals for discharge? What are your relationships with it? Are you covering these kinds of things? I'm kind of asking you about you. I mean, in your workplaces, in your clinicals, you're taking care of clients. Is there anything you would add to the list? Okay. I want to cover page 38, which has to do with HIPAA. Okay, anybody know what HIPAA is? We should. Can anybody tell me what HIPAA is? I could, please.
It's dealing with maintaining confidentiality of patient information.
Mhm. Mhm. Okay, so the HIPAA, Health Insurance Portability and Accountability Act, has to do with patient privacy and electronic medical records, like Destiny said, right? So the HIPAA rules give patients the right to decide where their information goes, right? Every time you go into a doctor's office or where any kind of medical facility, you're always signing a HIPAA contract, right? That means you have the right to decide who gets your information and who doesn't. Okay, there are 6 patient rights that are covered under HIPAA, and we need to know these. Okay, so in box 3.4, I believe on page 38. Okay, the 6 rights are consent. Okay, this means the patient has agreed to allow the provider to disclose their information or not. Notice. Okay. The provider's obligations are outlined regarding the privacy of the patient's healthcare information. Access. The patient has the right to inspect, always inspect a copy of their own medical record. And amendment. The patient has the right to amend their medical record for purposes of accuracy. Okay, accounting for disclosures. Providers are held accountable for how patients' medical information is handled. For example, at a nurse's station, you really can't be leaving patient charts out. You can't be leaving pieces of paper on the printer, on your whiteboards with your patients and assignments. You can't put a lot of information on that board, right? And then the other right is the patient has the right to restrict, that the provider restricts and uses disclosure of the information. Okay. So if a patient asked you, geez, they just had me sign all this paperwork and I signed a HIPAA consent, what does that mean? Would you be able to explain it to your patient, what it means? You should be able to. Okay. So that's what we need to know about HIPAA, the rights and what it is. Okay. Then the last part of this chapter I want to cover is violations of the law. Okay. So not only do we have to know about our own practice, the law about our own practice, for example, the scope of care. What is the scope of care that we have to act within? Okay. We also act as a patient advocate. We're always doing that. We're trying to speak for, protect the rights of our patient. But sometimes things happen, okay, that have poor outcomes. Okay, so negligence and malpractice we need to know about. So what is the definition of negligence? It's failing to meet the standard of care. So it's failing to do something that's reasonable and prudent, meaning common sense, sensible, careful, that any other reasonable person would do or not do. Okay. And malpractice is simply negligence by a professional person. right? So we don't act in accordance with our professional standards as our other peers would do. And that has to do with how we're licensed, how we're educated, and what our experience is. We have to be working within the scope of our role, LPN, RN. Okay. Example of nursing malpractice: if a nurse did not check the patient's vital signs after surgery, and there was some kind of a hemorrhage going on, and patient went into shock and died. Well, the scope of care, the nursing standards in a post-surgical patient outline you must do this, 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 and this. Well, if you do, well, obviously one of the things we're doing is checking vital signs. Well, if the nurse doesn't check vital signs and something's going on and the patient dies, that's negligence because we didn't follow the standard of care or best practices. Okay, so to prove malpractice, you have to have 4 elements that are present. Okay, a duty, a breach of duty, causation, and an injury. If even one of these 4 elements is not present, the nurse is not guilty of malpractice. For example, let's say the nurse made a clinical error that did not result in harm to the patient. The event would not be considered malpractice. However, it would be a deviation from your standards of care, maybe grounds for discipline, being reported to the board, or both. Okay, so let's talk about those 4 elements of malpractice. What is duty? All these 4 must be met. Duty is the obligation to provide care, due care. Right? So you have a duty to monitor the condition of a patient from whom you're caring for. And breach, what's the breach of duty? Failure to do that care. Okay, so nurse fails to check the vital signs. All right. Of a patient after surgery, or the nurse begins CPR on a patient that has a DNR. Okay, causation. Number 3, the nurse's action or inaction actually causes injury or harm to the patient. Okay, so there has to be a direct link between your breach of duty and the injury. For example, the nurse's failure to check the patient's condition led to an undetected loss of blood that caused the patient's death. Okay, so the failure of the nurse monitoring the patient obviously led to the death, which is considered the injury. And then there has to be an injury or damages. Okay, the actual harm or disorder that results from the negligence, right? And injuries are not, they don't just have to be physical. They can be emotional, they can be financial, pain and suffering, loss, not being able to go back to work, extended hospitalizations, or death would all be considered injury or damage in a negligence action. Okay. So we all know what standards of care are, what scope of care is. And you will have to become aware of what the scope of care is with your license when you get your license. In the study guide, there's two bullet points with regards to LPNs and delegation. You need to know what kinds of things can an LPN delegate to a nurse's assistant, number 1. And number 2, what kinds of patients can you delegate a CNA to take care of? For example, would you, an LPN, delegate a CNA to take care of an extremely unstable patient?
No,
No. What kinds of things can you delegate to a CNA and not delegate to a CNA?
vitals, assisting with positioning, turning patients,
Mm-hmm,
toileting,
mm-hmm,
bathing,
okay. What can you not delegate to a CNA?
assessments.
Destiny's carrying the load here for everybody. Anybody's participation is welcomed. So what can you not delegate a CNA?
Medication administration.
Thank you, Felicia. So assessment, medication administration, what else?
IV,
Feeding.
What?
IVs.
Okay, so that's all I wanted to cover in this chapter. Do you have any questions? So to go back and review, if you're going to go back and review pages 31, 38, and 41. Okay. Patient expectations of a hospital or of an inpatient stay. What should a patient expect when in the hospital? What is HIPAA? Okay, and what are the patient rights for HIPAA? Okay, and then malpractice and negligence. So those are the 3 topics. Okay. Let's go to chapter 14. And we'll cover a little bit of cultural aspects. Oh, shoot. Okay, I'm going to jump to our notes real quick. Okay, because our notes have a nice summary of what we need with regards to cultural aspects. Okay, so here, cultural influences. Okay, so culture is everything we believe to be true about the world. Okay, it's a set of beliefs, values, and assumptions about life that we pick through socialization in childhood. It's our culture. Different ethnic groups may have cultural similarities, but also cultural differences. But we're all unique, right? So culture encompasses a wide range of behaviors. Okay, so we're trying to be mindful of what cultural influences, what cultural aspects we need to consider when caring for our clients. Things we need to consider: language, touch, personal space, body language. What are their perceptions of health and illness? And their culture also influences family structure, childbearing practices, time orientation. Are they present oriented, past oriented, future oriented? And do they like eye contact or not like eye contact? When you're caring for your clients now, this is a question to you guys. When you're caring for your clients in your work setting or clinical settings, do you find yourself taking care of lots of different patients from different cultures? That's a yes or no question. Somebody could jump in and start this conversation because I have a few more questions about this. You guys take care of patients from different cultures?
Yes.
Okay. So Anthony, how do you gather this kind of information in this second bullet? Let's say you don't have it memorized about all these different behaviors, language, touch, personal space. You don't have it memorized about the Jewish culture, the Muslim culture, the Mexican culture, the Native American culture. How do you guys get this information?
When we talk to the patient.
Ask.
Ask them.
You ask the patient, what are your beliefs? What are you? Yes, absolutely. I mean, you're not expected to know everything, but you certainly are expected to gather the information that's going to be really important as part of their plan of care. Maybe they have different food preferences, food restrictions. Okay, so that's how we become culturally competent. We don't need to memorize everything about every culture, but we certainly need to be competent enough to be asking and learning. Right? So just said this, nurses must approach each patient as completely unique. Right? And we learn the patient's culture through observation and assessment. But the one thing we also have to do is check our own cultural beliefs and avoid passing judgment or stereotyping. Okay? And so when you may get a question about culture, about cultural aspects, and it says, one of the answers is, I'm just throwing this out there. Excuse me. I'm still dealing with this post-COVID stuff. You know, we want to be treated the same way as everybody. Well, different cultures are different, so that may not be the expectation. Patients want to be treated, or you want to be treated like what am I trying to say here? I'm trying to say that we treat patients unique. The old saying of treat people how you want to be treated, well, that may not apply if it's from a different culture, because both of your cultures may look totally different. Okay. Try and maintain an open and objective attitude towards individuals and their cultures. Avoid seeing all individuals as alike. Be aware of your own cultural beliefs and avoid projecting those beliefs onto others. Right? What is cultural awareness? Cultural awareness is our own self-examination and exploration of our own biases and prejudices. Right? Nurses who lack cultural knowledge and competency may feel inadequate or helpless. So, for example, what happens when you're driving down the street or walking down the street and you see a homeless encampment? What are your feelings? I mean, can you jump in there and help if you need to? What are your cultural beliefs? What do you do when you see panhandlers on the street? What if you're working with the homeless population? What if you're working with the LGBTQ population? What if you're working with the HIV population? Cultural competence is I mean, we're developing cultural competence through our whole nursing career. I'm still developing cultural competence, and I've been a nurse just about 40 years now. I'm still learning about different cultures. When I worked in the schools for 20 years, was exposed to many different cultures in our schools. And it was a great big learning curve for me to learn about different cultures and how they deal with discipline and absences from school and food preparation in the cafeteria. But we strive to be culturally competent. Okay, so to develop cultural competence, I'm in this bullet here. To develop cultural competence, we need to be sensitive to the cultural implications during each encounter. Again, avoid stereotyping based on race or ethnicity. always ask questions to try and engage in a conversation about learning about the client's culture. And that may be with the client or maybe discussing with the family. There are some cultures that the actual client maybe doesn't do all the talking. A family member does that for them. And avoid making assumptions about nonverbal cues from the clients from unfamiliar cultures. You know, there may be language barriers, there may be fear, there may be anxiety, there may be issues, concerns about immigration status. I mean, I have no idea. All the different things that these patients may be going through. Okay. Find out what's a priority in their culture with regards to nursing practice. What do they expect? If you need to get an interpreter, get an interpreter. If you need to, if there's low literacy levels, then maybe you need to get them simple handouts. See what resources your facility has. We want to avoid ethnocentrism. Do we know what that is? It's the belief that one's own culture defines the standards of behavior which all groups must be judged. That's not cultural competence, right? So whatever we believe, everybody else should believe. Okay. So that's our synopsis about cultural influences. How do you guys, I mean, what do you do when you're working with patients from different cultures? Do you enjoy working with patients from different cultures to learn?
Yes, I learn a lot from them, especially just different cultures, just how they do things, how
Sure.
their perspective is, their point of view, and it just helps me overall in general.
Yeah. Yeah. Anybody else? What's the positive side to learning about different cultures?
Learning something that's unfamiliar, something I didn't know.
Just adding to your foundation of nursing knowledge.
And being able to help more people too by understanding them.
Absolutely. And that's part of what we just talked about, patient expectations when they come into the hospital. That was that whole kind of generic list, but it applies to everybody, irregardless of what culture they're from. They expect high quality care and for you to be engaged in their care. Okay. Any questions about cultural aspects, cultural influences? Okay, let's jump to our Med-Surg book and cover chapter 45, or the parts of chapter 45 we need to. Okay, so this is caring for emergency conditions, trauma shock. Okay, and we're covering pages, we don't have to cover the whole chapter. Okay, we're covering pages 1048 to 1054. Okay. Okay, so we need to know this section. You're going to get asked about this on the exam. Okay, prevention of accidents. There's 3 areas that we talk about. We talk about home safety, highway safety, and water safety. Okay. So we know that accidents in the home and community are the 6th leading cause of death for all age groups. Typically, kids younger than 5 and older adults over 65 are the principal victims with accidents and deaths in the home. Right? So we need to be working with families if we're in community nursing. This is a lot of community nursing is primary intervention, which is teaching. Prevention before something happens. Okay, so these box 45.1 is highlighted because I need you to review this. Okay, these are some home safety tips when we're working with families. Most of it is pretty common sense for us, but you may get asked a select all that apply question that says, You know, what are the right answers for what you would teach a family client for home safety? Okay. What do we do in the kitchen? What do we do in the storage areas? Always trying to keep attics, garages neat and clean. Okay. Living room. What do we want to make sure in the living room? Floors aren't slippery. Furnace. We want to have a professional. We want to have our furnace checked, especially once a year, right? For leaks. January filters monthly. What kinds of things for home safety we're going to look at for the bathroom? Okay, this storing medication out of children's reach is key. Okay. Bedroom. Don't smoke in the bed. Use rubber mats under scatter rugs, stairways, and then general areas. Right? Make sure you have smoke and carbon monoxide alarms throughout the house. And then candles. Make sure candles are away from flammable materials. Never leave a candle lit unattended. Because so those are some home safety tips that we would work with our client. Highway safety. What kinds of things, what kinds of issues do we deal with highway safety? Thousands of people in the US are killed in car accidents each year. And 2 million are injured. And research suggests that improper driving, which is responsible for 90%, is typically from alcohol, drugs, distractions, fatigue, speed, excessive speed, emotional instability. So what kinds of things are we going to want to teach for highway safety? Seatbelts, right? Definitely teach with seatbelts. Better enforcement of the laws against impaired driving. Discouraging the use of cell phones. That has certainly helped decrease accidents and injuries for the states that have that in place. This is a pretty sobering statistic from the CDC that approximately 90 people per day die in a car accident. And also sobering that car crashes are the leading cause of death for 0 up to age 30. For the 30 years old and under, leading cause of death. Okay. And then we have water safety. Okay. What do you do if, let's see, the victim of a dive, let's say you have a victim, this is bolded, the victim of a diving injury, what do you do? Well, preferably you should not remove them from the water until EMS has arrived because of a possible spine injury. Right? You should try and immobilize the head and the neck, keeping the person out, the face from out of the water. Right? If the victim is not breathing and rescue breathing cannot be performed in the water, you're going to have to pull them out and start rescue breathing. And obviously, if they don't have a pulse, you're going to be starting CPR. And you learn this in CPR. If they're breathing, how do you place them? What's the position? You place them. What position should they be placed if they are breathing?
Put them on their side.
Because?
So they don't choke?
Yeah, what are you trying to prevent? Aspiration.
Aspirations.
Right. Okay. What is Good Samaritan law?
Means that you are protected from being sued if you are working within the scope of your practice to save someone outside of the workplace.
Yep. Thanks, Destiny. Excellent. The law guards against liability for care as long as medically trained individuals that we act in good faith. Right? And we act to the best of our ability. Okay. If a nursing assistant stops to provide emergency care, They will be held to a different standard than a healthcare provider who stops at the same accident scene. They're both expected to do the best they can within their scope of practice under the circumstances. Right? And just because we have a bad outcome, that's not proof of improper care. Okay. Whoops. Okay. Went through that. Okay. Some other kinds of trauma and emergent situations, shock, trauma, is a combative patient. Has anybody ever worked with a combative patient? What do you do? Nobody's worked with a combative patient before?
I used to.
Lots of training and education with regards to de-escalation, restraints. Many, many reasons the patient's combative.
We used to call our training ninja training.
Ninja training, yeah.
We
Worked
did
on a-
CPI.
That's what it is.
Yeah.
Oh, okay.
We just called it ninja training to make it more
Gotcha.
fun.
Mhm. Mhm. There's multiple reasons the patient may be combative. Okay, alcohol abuse, drug abuse, maybe lack of understanding of what's going on, again, from a different culture. Right? What my clients present with? Agitation, resistance, aggression. Right? And then who's not dealt with families who also become verbally or physically aggressive? Right? We should try and approach these patients and families, try our best in a non-threatening manner, using calm tone of voice, trying to remain calm. There may be language barriers, hearing difficulty, who knows? Okay, this is box 45.2 is a box that I'd like you to take a look at, the strategies for approaching a combative patient. Okay, because a combative patient is considered trauma. Okay, trauma it doesn't need to be a physical trauma. It's emotional trauma, mental health trauma. Okay. And then we're not, at some point in your nursing career, you are going to be working or dealing with violence. Okay. Domestic and intimate partner violence. Okay. Child abuse. What does it mean when we say that we are all mandated reporters? What does that mean?
Requires you to report any type of abuse.
Mhm. Is that just at work?
No, that's if you suspect your neighbor is abusing the child. Like
Mhm. What about in the
anytime you suspect it, you have to report it.
What about in the grocery store? Same, right?
Mm-hmm.
Elder abuse,
The same.
right? We know that the elderly population is increasing, the fastest growing demographic. People are living longer, right? So just by virtue of the numbers of the elderly, the abuse is going to increase. It's estimated that 7 to 10% of older adults are affected. Okay. As with child abuse, the law requires that signs of elder abuse must be reported. Okay. Emergency care given in many different places, clinics, hospital settings. Typically, it's associated with care out of the emergency department. Okay. One of the objectives for Healthy People 2030 is to reduce the proportion of patients who wait beyond a recommended time frame. Okay. Anybody think they might be going into emergency nursing down the road? Okay.
Nope.
Nope. How do we triage? What is triage? What is triaging?
Grouping patients and the importance of their care,
Mhm.
like taking care of the first patient or the person that needs the greatest assistance, and then kind of working your way through.
Yep. Prioritization. And so one of the most common methods of triaging patients is the ABCDE method. Okay. Obviously, A is airway, B is breathing, C is circulation. But when we're triaging, we add D, which is an assessment of neurologic disability. Okay. And then E is exposure, meaning that all areas of the body should be exposed so that injuries underneath the clothes are not missed. Okay. And then the rest of this goes through airway, breathing, goes through the 5 right here. Okay. I just need you to know what the triage process is. It's just not the ABCs, it's the A, B, C, D, and E. Okay. And then control of bleeding. Has anybody had Stop the Bleed training at their employer?
No.
Okay. Stop the really actually good training. It's now taught with CPR. You should have Stop the Bleed training as part of CPR recertification. I only know that because I'm a Red Cross, I was certified Red Cross instructor with the schools. And the last couple of years we added, it's called Stop the Bleed. So what we need to know about controlled bleeding, there's lots of things we need to know, but the most important thing is applying pressure. Okay. Have you guys gone through control of bleeding in Med-Surg? Okay, I don't know if anybody carries any kind of a kit with them in their car or whatever. I carry a little first aid kit that has like a tourniquet and the gauze and gloves and stuff. I've never had to use it, but
I usually carry a first aid kit. Well, I live in California and Texas, so we had disaster kits in our car. But
yeah. And then neck and spine injuries, right? We know most important thing, right, is trying not to move the patient until EMS is there, right? And they should be suspected. Any individual that has sustained multiple injuries, has fallen or is unconscious, you need to suspect a neck or spine injury. Okay. Car accidents, diving accidents, biking, right? Any situation in which the neck receives a significant force or blunt force. Okay. Okay. And then the last one is chest trauma. Okay. Penetrating thoracic trauma is less common, but is more likely to be fatal than blunt chest trauma. Okay. Anybody ever had fractured ribs? Fractured ribs are very painful. Breathing causes movement at the site of injury. Okay. Anybody know what the definition of a flail chest is? Have you guys studied chest injuries and med-surg? Flail chest is when you have 3 or more ribs that are broken. They're broken in a few places and your chest wall is unstable. That's called a flail chest, which produces your chest to rise differently on both sides. Okay. And chest injury a lot of times interferes with oxygenation, right? Because your chest can't expand normally. Okay. And from those chest injuries, pneumothoraxes can happen, hemothoraxes can happen. Okay. So that's what we need to know about that. I want to go back and review the second part of the notes, which were violence. Okay, and this is actually 145. Okay, just kind of a review. Violence is very common in the vulnerable populations, just like substance abuse is, right, for a means of regaining control. It's usually predictable and thus preventable, right, when we're looking at both victims and perpetrators. And throughout your nursing career, you're going to be working with victims of violence, perpetrators of violence. Okay. We know that we're mandatory reporters. We talked about that. We do not report violence against adults without their permission. Right? Do you know why? Why is that? Okay, the answer is that they must have an escape plan before the police are notified. Right? Otherwise, the violence may escalate. And then kids who are exposed to violence, right? If they're victims of violence or witnesses of violence, are at high risk for mental disorder, self-harm, substance abuse, and a completed suicide. Okay. And there's very little automatic follow-up or counseling for these kids through our criminal justice system or mental health systems in most communities. We know that abuse is about power and control. And all these methods are about control. Right? Generally with family violence, it's usually the most powerful against the least powerful. And then we know that family violence is perpetuated in a cycle as a child grows up, seeing violence used as a method to method to control. Whether it's controlling the kids, controlling the mom. And then we know that abused kids are more likely to perpetuate violence or tolerate violence in their own relationships. Okay. Families living in poverty. We've talked about this before during this class. Families living in poverty. Families with economic strain, dealing with crisis, are more likely to experience violence. And then this is what's been going on the last 2.5 years with our pandemic. The social isolation of our kids contributes to violence. With the reduced social support, right? And that's what the kids have had over the last couple of years: isolation, lack of social support, lack of school, in-person school. And what are we starting to see as the results of that? A lot of kids with a lot of issues, right? Anybody working with these kinds of kids? I had a student in my last class that does volunteer work at a shelter, a kid's juvenile home. And she said she's never seen anything like it in the last couple of years. Anybody work with kids, at-risk kids?
I work with disabled kids, but I mean, their stories are all different. So there's some in there that's been abused, there's
Yeah.
some that were birth traumas. So it's
Yeah.
a variety.
Mhm. And then we touched on elder abuse. It's also a type of family violence. Right? You can go ahead and read through these, but we read through the rest of these notes. What kind of symptoms victims of violence may exhibit? What about women who are abused? What risks do they have? And one of the most important things here is when you suspect any kind of abuse in an adult, you have to try and give them the opportunity to try, and you want to encourage them to report without feeling shame or guilt. It's really hard, but you really want to try and get them to report what's going on. And then we have the issues of suicide, which is obviously violence directed at yourself, oneself. It's a second leading cause of death in young adults, ages 10 to 34. What my kids present with, being in the schools, this was common. Depression, unintended pregnancies, STDs, HIV, relationship violence, intimate partner violence, substance abuse, and maybe a prior suicide attempt in the patient's family. Okay, I did a lot of this primary prevention in the schools, a lot of education in the schools with the middle and high school kids, trying to help them learn coping mechanism, teaching parents good coping skills, anger management programs. Okay. So those are the where is my looking for my whoops. Study guide. You guys still with me? Does anybody have any questions? That's our
Yeah, we're with
content.
you.
That's our content for tonight. Okay. Yeah, anybody have any questions? It's hard topics, especially the violence topics. They're hard topics. Okay, and the ethics and a lot to consider.
Yes, ma'am.
Nursing is a big job. Lots of things to consider. I'd like to review the study guide briefly and show you how it's organized, so that it doesn't become so overwhelming for you. Okay. At this point, well, first of all, does anybody have any questions on any of the content we just covered? Okay, let's go through the study guide. I want to show you how it's organized. Whoops. Hang on, I need to get back and share my screen. Okay, can everybody see it? Okay. There should be nothing on the study guide as far as the topics that you're unfamiliar with. At this point, you should have heard everything. Not every single thing in the study guide. We've covered all the topics. You will need to do your own studying. Okay, so studying comes from, well, we'll get there. Week 7, 8, and 9. I have summarized your readings for you from 7, 8, and 9. So it's a easy go back and see where things came from. So you're not flipping through all your books. Okay. Same kind of exam, 50 questions, multiple choice, select all that apply, math problems. Here's a couple of, after doing reviews for the last 9 weeks, here's some of the common problems I'm finding. And I'm just going to give you some tips. You have got to be able to pull out the important words, phrases in a question. Okay? You have to. You have to be able to pull out the priority words. You have a blank piece of paper next to you. Write the word down. I don't know, great, least, first, last, initial, most important, whatever your priority word is. If you see it in the question, pull it out, write it down. Okay. Read the question a couple of times. Okay. You might not have picked up on something the first time. Okay. If after a couple of tries, you have no clue what the answer is, just make the best guess you can and move on. It's one question. Don't get stuck with the one question. Do it for 10 minutes. Okay, it's going to increase your anxiety, decrease your confidence. So keep moving. Okay. The other thing that I suggest is that you read the question and I don't know, look away, whatever, cover the answers. Try and come up with your own answer in your head. What would be the right answer? And then go to the answers and see if it's there. Or see if something's close to being there. Make sense? Okay. Do not change your answers unless you can specifically talk yourself out of why exactly the first answer you selected was wrong. Okay. Not because, oh, I think I read it somewhere. I think I remember somebody saying it. No. Don't change answers because of uncertainty. You should have a valid reason. You should be able to talk yourself through a valid reason to change an answer. Make sense? So there's some tips for me. Basic math questions. I've given you math resources, formula setups, IB Calc, how to do IB calculations. At this point, hopefully you're not struggling with math. But you know, review your math handouts and do practice questions. You should all be doing your, I hope you're doing your NCLEX questions that are coming from you guys doing your student resources. Are you guys doing NCLEX questions weekly? Hopefully. As much practice with that as possible. Okay, so best practice to prepare for the exam. Readings. Review your readings. And remember, when you go through the readings, it's if there's specific pages to cover in a chat, and like for example, in chapter 3, there's only 3 pages to cover, 35, 38, and 41. You're not responsible for all of chapter 3. So don't overstudy. Okay. Weeklies, if you didn't attend class, I highly suggest you watch the recording. Try and attend a review. This is kind of a mini review because I don't know how many people can attend Sunday. So I'm just trying to get you started. If you were in lecture and missed part of it, had to leave or go do something, go back to the part of lecture that you missed and listen to it. As this study guide is based on lectures, notes, your weekly notes, and your readings. Okay, it's all those 3 are all put together then, and I've done my best to organize it all for you. Okay, so these are different topics we covered during the last 3 weeks. Okay, and you can go back right up to the top and look at the readings. Okay, so your first topic down here is sexually transmitted diseases. Well, it was covered in week 7, chapter 41, care of patients with sexually transmitted diseases. Okay, so I even told you up here what chapter and what book. Okay, so this is what I want you to know about HIV. These 5 bullets. This is what I want you to know about chlamydia. These 6 bullets. Okay, so again, I'm showing you how this is organized. We're under STDs. So we've got 5 different STDs I want you to know about that we've gone through. HIV, chlamydia, syphilis, herpes, and HPV. I'll say it again, like I say with all the, this is actually the first term that this is my first term teaching in PN, but this is the first term you guys have had study guides. There hasn't been any study guides before this. So I think they work well. And so I wanted you guys to have them. Okay. Let's see, our next section is infection prevention and control. Okay, this was covered, I think, in week 7, chapter 17 in your fundamentals book. Not the whole chapter, just these pages right here. Okay, so don't go back and start reading the whole chapter 17. Okay, what kinds of infectious disease, infectious conditions do we want to know? Do I need you to know about? Okay, hepatitis. And I've highlighted all the sections. So this is the big kind of the overview. Infection, this should say infectious diseases and prevention. And prevention and control. That's what it should say. So hepatitis, TB. Okay, if you have a good understanding of this study guide, I'm telling you, you will score in the 90s on the exam. Okay. TB, smallpox. What happens with smallpox with an early rash? This whole section is quite a bit about smallpox. All right, early rash. And you get to the pustular rash and scabs. Okay, so that whole section's about smallpox. Okay, so those are the 3 I need you to know about: hepatitis, TB, and smallpox with regards to infectious diseases. Now, as far as infection control and prevention, what do we do with foodborne illnesses? What do we do with food safety? Here's some ideas. If you're teaching a family, a client about food safety, here's some of the things that you might want to mention. Okay, so we have foodborne illness and food safety. And then we have waterborne illness. What happens when you got bad water, right? Waterborne pathogens are usually, they enter the water through animal and human fecal contamination. What's some common waterborne illnesses? Cholera, Giardia. Okay. What are vector-borne illnesses? Okay. You guys know what vector-borne illnesses are? What are they?
It looks like diseases carried from like animals or mosquitoes.
Mosquitoes, ticks. There's 4 vector-borne illnesses I want you to know about: Lyme, Zika, Rocky Mountain, spotted fever, and malaria. Okay, Lyme and Rocky Mountain spotted fever are transmitted by, you get it from a tick, a certain tick. Right, and then the Zika and the malaria are with mosquitoes. Okay, next section is disaster. It's chapter 44 in Med-Surg. I don't really know what week we covered it. And I think it was week 7. Right here, chapter 44, care of patients in disasters or bioterrorism attacks. Okay. Okay, what do I want you to know about that? What do we need to know about that for the exam? There's 2 types of disasters. They're natural and man-made. What's a natural disaster?
Like a tornado, a hurricane.
Earthquake, tsunami.
What is a man-made disaster?
That's a good question.
Pollution,
A
fire.
bomb.
Pollution. Yeah, good job there. Wildfires.
Wildfires, water supply contamination, they're man-made. Okay, I also want you to know about Healthy People 2030 objectives with regards to disaster management. And all I want you to know is that the objectives focus on preparing, alerting, and caring for a disaster within a population. Okay, that's a general blanket objective. Right, focus on preparing, alerting, and caring for a disaster within a population. Okay. One of their specific goals to meet that objective is messaging, communication. Right? How can we do a better job with our emergency messages to protect the public? Okay. I want you to know how to teach a family how to prepare a kit for a disaster. Okay. There's a few things that I've highlighted. I just did my review before this, so I've been highlighting what's important in a kit for a disaster. Let's say you're the community nurse and you're preparing. You're teaching families how to prepare. What do they need to know? A couple of things. Stock and think of this maybe as a select all that apply question. Right? This has lots of information in it, this little paragraph. What do they need to know? Stock enough food for 3 days, number 1. Review the kit every 6 months, number 2. Ensure all members of the family know where the kit is located, number 3. And then everybody should know how to turn off utilities in the house, number 4. Okay. What's the purpose of a mass casualty exercise? Well, anybody ever participated in a mass casualty exercise? It's pretty wild. Anybody ever done that? Well, the purpose of it, one of the purposes, the main purpose of a mass casualty exercise is to evaluate the agency's response. How did we do? What did we do well? What needs more work? Right? How much time did it take for EMS to be activated? Did their early response systems work? Okay. Who is the federal agency that helps out in a disaster? Okay. It is right here, National Response Framework. What do? I've highlighted it for you. Right? They help with transportation. So if you get a question, what federal agency assists once a disaster has been declared? What agency kicks in? I don't know. National Response Framework is one answer. CDC, NIH. Okay.
I thought it was FEMA. It's not FEMA.
It is FEMA. FEMA is really kind of the big picture. Okay. These are the people that get right in there.
Oh, okay.
Okay. But yes, FEMA is the big dog there. But maybe you get a question. National Framework Response is the agency that is first when a disaster is declared. They're the agency that steps in. What do? Select all that apply. I'm just throwing that out there. Select all that apply. Well, they do transportation, temporary housing, medical resources, search and rescue, and firefighting. So when you read through these little paragraphs, these little bullets, just think to yourself, what are they going to ask me? If this was a paragraph that had lots of information like this, maybe that's a select all that apply question. Okay, up here, where was the other one that had all the definitions in there? Just think about, okay, kit for disaster. There's a lot of information in that little paragraph. Would that be a select all that apply question? Or what if it said, in a kit for disaster, stock enough food for 10 days? That wouldn't be a correct answer, right? Okay. Okay. Okay, so chemical spill. What do you use for chemical spills to remove clothing?
Tongues.
Thank you. Here's 3 different kinds of agents that clients may be exposed to. And what is going to be their primary impact? So for Veskin agents such as mustard gas, it would be dermal or skin and respiratory. What's an example of a nerve agent? Sarin gas. What's that complication? Respiratory. What about blood agents like cyanide? Again, skin and respiratory. And obviously we follow the ABC protocol for all chemical disasters. ABCs. Post-op. Again, I know you guys are exhausted. I'm just showing you how this is organized. So the next section is post-op care. What do we want to know about post-op care? Okay. What are some potential complications? How do you do an assessment? When can they go home from the ICU? Okay. Or not home. When can they go to the floor or the unit? Wherever. Or some thrombophlebitis can be a post-op complication even days after surgery. Right? If you have history of smoke, you're going to be at higher risk for post-op complications. Last week we went through all these next ones. We went through all of it. Cirrhosis. You're going to get a question about each one of these. Cirrhosis. What are the interventions? Peripheral artery disease. What is it? I'll give you a little paragraph on what it is and what are the interventions. Okay. Chronic venous insufficiency. What is it? What are the interventions? Hypertension. What is it? Hypertension is a little bit bigger of a section. What are the causes? What contributes to it? What are some interventions? And then your chronic venous insufficiency, again, right here, you have a nice summary of what it is and your interventions. Okay, same with diabetes type 1 and type 2. That was all the med-surg conditions we went over last week. Okay, there's your type 1 and type 2. Remember hypoglycemia, low blood sugar. What do you need? Sugar. It's low blood sugar. It happens quickly. It needs to be treated quickly. Okay, hyper, too high. One of the very serious complications of hyperglycemia is your DKA, your diabetic ketoacidosis. I'm sure you covered that in med-surg, right? Did you guys cover type 1 and type 2 diabetes in med-surg yet?
Yeah.
Yeah.
Yes, ma'am.
Okay. There's a little section on hospital-associated infections. Okay. Proper hand hygiene before and after patient care. N95 for airborne diseases such as TB. What are contact precautions? Right? We want to prevent any exposure to secretions or body fluids without having gloves on. From wounds to soil dressings to soil bed sheets. And then we talked about this. Here's the HIPAA section. Okay, what's HIPAA? To protect sensitive patient health information from being disclosed without the patient's consent or knowledge. Okay. Then we cover malpractice. Okay, covered that tonight. And then cultural considerations of knowing, here's just some examples, things that we need to know about. We don't need to know, but things that might play a factor into the patient care plan, what their preferences are, what their culture is. Okay, and I talked about your LPN scope of practice. What can and cannot be delegated to a nursing assistant? And what types of clients cannot be assigned to nursing assistants? Okay, and then we went through this tonight too. So I need you to go back to, let's see, page 45, chapter 45 was right at the beginning. Pages like 1048. It's probably 1048 through 1050. And I need you to review home safety, highway safety, water safety. It should be nice, fresh in your mind tonight. So we just went through it. Okay, so all the sections, I should probably take out all the rest of my yellow because it's probably confusing, but I've tried to break this down into sections for you. And everything, every section that's highlighted are from your readings. Okay, infection prevention control. That was your hepatitis, your TB. All right. Patients with STDs. You've got a section down there on that. Patients, disasters. Okay, post-op care, cirrhosis, diabetes. We just went through all that. Okay, and then we went through this tonight. Okay, so every section in your study guide should cover what was in your readings. So you were following along with me. Is that helpful?
Yes.
Yes, it was.
Okay, Candy, I don't recognize, where are you from? You from Dr. Kershaw's class?
No, I'm from your class.
You are?
Because if I log in from my
Oh,
phone,
yeah.
it's Candace Ashizawa.
Yeah.
I'll be trying to fix it. There we go.
That's okay. No, don't worry about it.
It should stay. I don't know why it
Yeah,
changes
no worries.
every time.
So, let's see, it's 7:26. Does anybody have any questions? Hopefully this is a jump start for you, for studying. Hopefully, I wanted to show you how the study guide was organized. So I know it's 20 pages, but I bet if I decrease the font by 2, it would be 12 pages. So I put this together. I tried, from scratch. So I tried to do the best I could, getting it organized for you, but the last terms haven't even had one. So anyway, just trying to help you guys out. We're all trying to get over the finish line together, aren't we?
We appreciate it. Thank
Yeah,
you.
you're welcome. You're welcome. Anybody have any questions?
Professor Marvel, on the HESI prep, the assignment where it's got all the topics,
Mhm.
I just want to make sure I've been doing this right. Are we supposed to be putting like under, like for the different topics for bioterrorism and all that, just like the what it is and what the prevention and all that? Or is it something else specific we're supposed to be